Hi, everyone. Thank you for joining us today. We're going to get started in just a few. Hello, and thank you for joining today's Community Connections event discussing RSV. We are glad to have you all tuned in today to hear about this important topic. My name is Casey Reed, and I am with DiMaggio Children's Hospital, and I'm moderating our session today. In a moment, Dr. Herschel Scher will present, but before we begin, there are a few housekeeping items to cover. This webinar is being recorded and is streaming live on Facebook. Today's session is meant to be interactive. We want to hear from you. To do this, put your questions in the chat box for those tuning in via Zoom and in the comment section on Facebook. Thank you to those who have already sent in questions. Dr. Scher will be answering them shortly. Finally, if we are unable to answer all of your questions, we will send out a follow-up email with answers. Facebook listeners, check the comments for instructions on how to send us emails to be included. Community Connections is brought to you by the American Lung Association and proudly presented by DiMaggio Children's Hospital and Memorial Healthcare System. Dr. Herschel Scher is a board-certified pediatric pulmonologist, and his patients represent the full spectrum of pulmonary conditions and allergies from infancy to adolescence. The main conditions he treats are asthma and cystic fibrosis. Dr. Scher's research interests include clinical pharmacology of drugs used in respiratory medicine and respiratory infections in cystic fibrosis patients. He is currently running the DiMaggio Children's Hospital Pulmonology Research Division, where he participates in national and international research studies. Seeing very sick patients recover and being able to make a difference in their lives is very rewarding for Dr. Scher. He most enjoys the basic interaction with the patient and family and improving the lives of the children. He looks forward to coming to work every day and bringing smiles to their faces. In his spare time, Dr. Scher likes playing golf, watching sports, reading, and the outdoors. I will now turn it over to Dr. Scher.
Thank you to the American Lung Association for having me present on RSV, which is a very relevant topic. Next slide, please. So we're going to discuss RSV in children. So the RSV virus is an RNA virus initially identified in chimpanzees in the 1950s, and then was identified in humans as well. So this picture on the right-hand side shows the virus, and it has a cell membrane, and the two important factors are the attachment protein up at the 11 o'clock position and the fusion protein at the 12 o'clock position. So what happens is that the virus attaches to the cells in the airway by this attachment protein, and then the fusion protein fuses and attaches to the host membrane, and the virus then enters the cell where it then replicates, and it basically takes over the cell. And then it moves to the adjacent cell, and it forms what we call a syncytia, which adjacent cells fuse, and it looks almost like a carpet of virus. There are two strains of the RSV virus, A and B, and it's differentiated by this attachment protein. And the RSV-A tends to be a more severe virus with increased ICU admissions. Next slide, please. So this is just showing the basic pathophysiology, what happens. And you see the one on the left is the normal airway. It's got a very nice patent airway, and there's where it says the normal epithelium, you see that pinkish layer is very thin. The one on the right is where there's bronchiolitis with RSV, and you see that the airway is narrowed, there's tissues inflamed, and therefore there's swelling of the lining of the mucosa. And what can happen is that there may be damage with necrosis of the lining of the epithelium, which includes cilia. So these cells have like little hair-like structures which sweep upwards to clear the mucus to the throat, and that you can expectorate the mucus. So the RSV virus damages not only the mucosa by the sloughing of the airway mucosa or the lining, but also damages, therefore, the cilia and therefore impairs mucus clearance. Next slide, please. So initial infection occurs as infants and toddlers. About 90% of children have been infected at least once by their second birthday. There's numerous subsequent infections throughout life, as you only have partial immunity to the RSV virus. Tends to initially occur as an upper respiratory illness, but then can progress to lower airway with bronchiolitis, which basically means inflammation of the small airways. The majority of these patients with severe RSV are actually full-term babies, although, as we'll see later, the preterm infants have more problems. Typically, RSV occurs from the fall through the spring, more or less November through March, although the season is longer in Florida. But what's happened within the past year is that this whole, it's been disrupted, and we'll see in subsequent slides. Next one, please. So, about 2 million children under the age of 5 experience RSV infections. About 60 to 80,000 are hospitalized annually in children under the age of 5. There are unfortunately about 100 to 300 deaths annually in that age range, and the cost is very high, ranging from about 880 million to 2.3 billion. What's also interesting is that there's increased RSV in the Alaskan Native and the American Indian children. On average, about 2 out of every 100 infants under the age of 6 months with RSV are hospitalized, and there's a 16% increase in hospitalization in the first year of life in patients who have RSV under 1 year of age. Next slide, please. So those who are at greatest risk for severe RSV are the very preterm infants, infants under the age of 6 months, children under 2 years of age with chronic lung disease or significant congenital heart disease, those with immune deficiency, and those with neuromuscular disease. And part of that is that they have impaired clearance of their secretions and mucus. Next slide, please. So RSV can be transmitted either airborne with individual coughing or sneezing, or by direct contact, such as kissing or touching surfaces and then touching your hands. And RSV virus can survive on surfaces for up to 12 hours. And the virus can then also enter the nose, the mouth, or the eyes. And the eyes, the virus goes by the nasolacrimal duct into the nose and then is transmitted to the airway. Next slide, please. So this is the time frame for RSV. So you see you're exposed to the virus. There's an incubation period of about 2 to 8 days with a mean of 4 to 6 days. You're contagious for about 3 to 8 days, but you may be contagious for 1 to 2 days before you actually demonstrate symptoms, and typically are symptomatic for 4 to 6 days after being infected. It typically resolves within 1 to 2 weeks, but there could be a longer contagious period in people who are immunosuppressed, and they may secrete virus for 1 month or longer. And we can see that the symptoms typically are runny nose, sneezing, fever, coughing, and wheezing. Next slide, please. So this is just contrasting the various conditions. As we can see with RSV, which is on the extreme right, that wheezing seems to be the most prominent feature. You can have the fever and difficulty breathing, whereas with influenza, it tends to be more muscle aches, fatigue, and fever. Obviously, nowadays we have to think about COVID. Although COVID did not affect children as much as or severely as it affects adults, but they're presenting with difficulty breathing, fatigue, sore throat, and the common cold typically presents a sore throat. Next slide, please. So when should you seek medical attention for your child? As so many children are contracting RSV, but most of them can tolerate it fairly well. So if symptoms are not improving or worsening, high fever, and a high fever in a under 3-month-old, that should actually be 100.4 degrees Fahrenheit or 38 degrees Celsius. And those who are 3 months or older, 102 degrees Fahrenheit or 39 degrees Celsius. Increased work of breathing, labored breathing with coughing, wheezing, retractions, flaring of nostrils, all signs of the child is having a hard time breathing. Particularly the infants and those within the first month of life may have respiratory pauses where they stop breathing for up to 10 seconds, or if it's longer apnea episodes, there may be a bluish tinge to lips or nails, indication that their oxygen saturation is low. And obviously they can dehydrate, and this can happen because they're not drinking fluids. There may be fever or rapid breathing where there's evaporation of secretions. And so if they're dehydrated, there may be few wet diapers, they may not tear, or they may be lethargic with decreased activity. Next slide, please. Next slide. So diagnosing, obviously the history, the physical examination, and then studies. One can do nasal swabs, nasal washing, rapid antigen test, which is less accurate. It's about 80% sensitive. It's a lot easier and cheaper. The PCR or polymerase chain reaction test, it's a more specialized, more costly, but it's a more accurate test. And then chest X-ray is not always indicated. If the child is not very ill and looks like just a cold, you may not need a chest X-ray. But if it looks like they're working hard to breathe, or it's certainly gone, for lack of a better word, gone for chest, then one could do a chest X-ray, which will show evidence of mucus inflammation. There may be collapse of the airways, and the airways may be hyperinflated, as seen in that second slide. Next slide, please. So how prevalent is RSV? So the slide on the left is the slide of the US itself, and you can see that there's 2 peaks. And this is actually, this is from the CDC from last week. And if you looked at this 2 years ago, this would look totally different. So the initial peak, which is the lower peak, is last year over the summer. And the second peak on the right-hand side, that is the one from this year, and that ranges from September through currently. And the blue is the antigen testing, which is the less accurate, with the sort of purple is the PCR testing, which is a more accurate test. So you can see it peaked and then it went down over the basically over sort of the spring. The one on the right-hand side is Florida. And we know in Florida that the RSV season is much longer than the rest of the country. And typically that's Florida south of Orlando. And obviously I'm interested in Florida since I'm in South Florida in the Hollywood area. And you can see that the peak is higher and it's more prolonged. If you compare the 2 slides, you can see that it's a much wider peak. And then whereas in the rest of the country, it was decreasing, and you see that they got a peak again back in Florida around October. So next slide, please. What I'm illustrating here is just to show you, the percent positive. So the one on the left is from 2021. You can see in February, March, when probably most people are still in their homes due to COVID, there was a very low percent positive. 3% or higher is significant. And you can see that it picked up significantly around May. The one on the right-hand side is the current from August through currently. And you can see in August, it was high. It then went much higher through November. And then actually since December, the numbers are coming down significantly. And the other thing, if you look at the actual, in the last column on both sides, is the total PCR tests. And you'll see that actually last year they did more testing. And why that is because RSV being so prevalent this year that many times they may not have done testing on every patient because it was almost assumed that the patients had RSV. Next slide, please. So this is comparing similar time from June through December. On the left-hand side is 2021, on the right-hand side 2022, and you can see that we had a lot more RSV in this past year, significant, almost to 4 times the number. Next slide, please. How do you treat RSV? Well, that all depends on the symptoms, the age, and health status. So most patients are going to need fluids because they may dehydrate and because they're very congested, particularly with infants. And infants typically breathe exclusively through their noses until 4 to 6 months of age. So if their nose is very stuffy, they're not going to want to drink because they'll have a problem drinking with a stuffy nose and a bottle or breast in their mouth. You want to suction nasal secretions, flush nasal passage with saline. Nutrition is important, either if they can drink by mouth or if they cannot, then you may need to pass a nasogastric tube. Some of them may need oxygen and hospitalizations. And then bronchodilators and steroids, it's more controversial. We used to use this a lot more in the past, but now we're not using bronchodilators all that often, and that's albuterol. But sometimes we're doing is nebulizing saline, normal saline, which just helps moisturize the airway mucosa, or we're using racemic epinephrine, which reduces the inflammation of the airway. Steroids such as prednisone are not being used much. So obviously, some kids may need ventilation. Those who are very ill may need mechanical ventilation, and those typically are admitted to ICU. Antivirals, of which there's one called ribavirin, and this is not used much because it needs to be aerosolized for 12 to 18 hours a day for 3 to 7 days. It's toxic and teratogenic, so any nurses who are pregnant cannot care for these patients. So it's used in the sickest patients, and those typically are patients who are transplant recipients. Next slide, please. So vaccines, so initially there was a vaccine in 1966, inactivated vaccine. This was discontinued because of adverse effects. 2 patients died, 80% of the babies were admitted to hospital. And the problem with vaccines is it's very difficult to trigger immune response in babies who have an immature immune system. So what we've had more recently is passive immunity, which is a humanized monoclonal antibody. Does not require activation of the immune system. Actual antibody is made in a factory and administered to the babies. Next slide, please. So there are 2 monoclonal antibodies. The one on the left, pulmonologist, Synagis, which is currently being used. It may be that some of the audience families and their children may have been treated with this. So it came on the market in 1998. The strict American Academy of Pediatric criteria, typically used in the preterm, and that's a very preterm patients under 29 weeks of age, chronic lung disease, significant congenital heart disease, neuromuscular disease, and some of them may get it for a second season. But typically it's given for 5 consecutive months, although this year the insurance company is more lenient because of the prolonged and extended season. On average, about 2% of babies receive it. The Sunride is a new one, which is not yet authorized in the US, but is authorized in Europe. So it tends to be used in the later preterm and term infants. It's a single injection because it has higher potency and a longer half-life. Therefore, it stays in the body for longer. And hopefully this one will be authorized and cover and be eligible for more infants. Next one. The vaccines, this Novavax vaccine was actually administered to pregnant mothers. Although there was no statistically significant decrease in what is called medically significant lower respiratory tract infections, there was a significant reduction in hospitalizations for RSV-related lower respiratory tract infections. And interesting, the vaccine was a lot more efficacious in lower middle income countries such as Philippines, South Africa, Mexico. Next slide. This may actually be one of the more important vaccines. How do you prevent RSV since it's so prevalent? And washing hands, they recommend washing hands for 20 seconds, using hand sanitizer, breastfeeding, obviously transmitting antibodies to the baby in the breast milk. And these antibodies usually last until 6 months of age. Avoid sharing utensils because obviously the RSV can survive on various toys, cleaning, disinfecting surfaces and toys. Avoid contact with sick individuals. You know, if your child is sick, don't send them to childcare. And avoiding tobacco smoke exposure, because what tobacco does is it modulates this inflammatory response with enhancing the inflammation and suppresses the body's immune response, and therefore the virus can replicate. This slide.
Dr. Scher, I have a few questions from the audience, if we want to take some of those.
Yeah, so I mean, that concludes my presentation, and I'm very happy to take questions from the audience.
So Beth in the audience wants to know, are RSV rates worse in some states or regions than others? I'm particularly interested in Florida and southeastern US.
Yeah, so correct. So in fact, if you, Casey, if you can go 2 slides on.
Back?
No, forward, go forward. There's this.
Next one.
So this slide. So this on the left-hand side is southern US, the right is Florida. So you can, so you can see that there's 2 definite peaks, but the peaks are much narrow in southern US as opposed to Florida, and they're not as prolonged. And in fact, the CDC collects data, and there's a website called cdc.gov/prevalence where you can actually look and see. So if you were looking at New York, you would see a flat line, and then you may see one peak, and that's typically in the fall through the winter. So definitely, it's a lot more prevalent in the southern states, whereas in the northeastern states, it's less prevalent, and if you go to the west, it's US, it's a lot less prevalent as well. So there is a definite difference. And it's thought, you know, people are sort of thought, why is it South Florida higher? It may be that maybe there are more people, you know, snowbirds, snowflakes coming here, bringing their viruses. It may not be cold enough, you know, for frost to kill off these viruses. But it's definitely south of Orlando. We certainly see a lot more, and it's now recognized. Initially, it was not that well recognized by the insurance companies, and they've been more lenient with authorizing the monoclonal antibody.
Thank you. Carolyn wants to know, are elderly people also getting RSV and people with weakened immune systems?
Correct. So can we go 1 slide ahead?
Yep.
So yeah, so although I'm a pediatric pulmonologist, you know, we do also sort of think in terms of the broader picture. So the adults with increased risk of RSV are those older than 65 years of age. They've got pulmonary or cardiac conditions, COPD or other heart conditions, immunocompromised. And here we see that there's actually greater hospitalizations, increased numbers compared to children, and unfortunately also a lot more adults are dying with RSV. What is good news is that there are actually 4 different vaccines that are being developed and in various stages of development, and they seem to be efficacious.
So the next question we have here says, how does RSVP impact my child in short and long term?
The short term, obviously, your kid can get sick, as we've gone through those symptoms, and they may be sick enough to need to go to the pediatrician frequently or be hospitalized. But luckily, most of them, if it's a fairly well child and it was not preterm, they will get over the virus within a week or so. Long term, they found that the patients who older than 6 months of age and requiring hospitalization for RSV may develop recurrent wheezing or may develop asthma later in life. There's about a 2- to 4-fold increase. And this was a study that was conducted in Australia. At one stage, people thought it may make you more prone to allergy, but it does not seem to be a factor due to RSV infections.
Thank you. 2 more questions here. One says, how long should a child wait to return to daycare after an RSV diagnosis? Is that different for a medically fragile child?
So a child who's not medically fragile, typically they say about 8 days after onset of symptoms, but that will depend. I mean, if a child is a lot better sooner, you may consider that. And the criteria that many people use are the child does not have a fever for 24 hours and they have not received any antipyretics. So no Tylenol, no Motrin. They may still have a mild cough, but there's no wheezing and they're able to eat and drink well. The medical complex children will also depend on exactly what condition these children have. Obviously, those who are immunocompromised may share the virus for longer, up to 4 weeks, and there I think it would have to be on an individual basis. But I think as a general statement, I'd say the medically complex children will probably need to stay home for longer periods of time. And the one thing that I think is important is to stress to parents, if your child is sick and has RSV, think of the other people and the other people's children in daycare, because if you're sending a sick child to daycare, it's a good chance that a lot of more children in the daycare are going to get sick.
All right. Thank you. And our last question says, should antivirals be administered to RSV positive children? If so, which one?
So at present, the only antiviral we have is ribavirin, and I touched on that earlier. So this medication inhibits the replication of the virus. As I said, you need to nebulize. The typical dose is 6 grams in 300 milliliters of fluid. It's nebulized for 12 to 18 hours and for 3 to 7 consecutive days. So it is very labor intensive, and it's used in the patients who are the sickest, and those typically are children who've had organ transplants or severely immunocompromised, but it's not used as a routine medication. And the other interesting thing is that pulmonologist, the synergist, that is not used with an acute RSV infection. So it's used as prevention, but it does not help if you've actually got the RSV infection itself. In the past, people did use intravenous immunoglobulins, that's serum which contains high antibodies, high titer of neutralizing antibodies, but this is no longer used. And there are some other medications that they're busy researching, which are the newer ones, looking at various, where they can interrupt the virus, called fusion inhibitors and various things, but these are still very much in infancy, and probably will not be available for numerous years, if at all.
So, that concludes our questions. So thank you so much, Dr. Scher, for your time today. And thank you all for attending today's American Lung Association's Community Connections event. DiMaggio Children's Hospital Memorial Healthcare System are proud to partner with the Lung Association to bring this educational series to our local community. For the questions we've been unable to get to today, be on the lookout for an email coming in the upcoming week with responses. To learn more about RSV, including available free programs, support groups, and resources, visit www.lung.org. Also, don't forget to follow the South Florida American Lung Association Facebook for announcements regarding our next Community Connections event. Follow us at Lung South Florida for details. Until next time, thank you, Dr. Scher, and all who tuned in today. Together, we can improve life one breath at a time. Have a great day.
Thank you, and everybody have a good day.